recommending patients for coronary artery bypass surgery based upon their coronary anatomy, based upon their history, their age, coexisting medical conditions, their left ventricular function, and many other aspects. So let us dive deep into and get a better understanding of which patient would benefit better from coronary artery bypass surgery versus coronary intervention. And this is an important distinction that we have to make as cardiologists. This will be a great learning lesson for a new cardiologist who is starting cardiology rotation. It is a great resource for somebody who is studying cardiology boards, so you know what is a class 1 indication for a certain procedure, what are the procedures that we need to be avoiding because they could be doing more harm than good, and it could be good for practicing cardiologists to use this as a roadmap based upon the patient you have across the table, based upon their complete medical history, what is the right recommendation that you want to do. And that's what this presentation is going to help you to make that decision. So let us begin with the feature presentation. This presentation is based on 2021 ACC AHA guidelines for coronary artery revascularization. This is the latest guidelines, and this should be good for next 5 years. So if you understand everything in this presentation and the previous presentation which I did on coronary interventions guidelines for 2021 by ACC and AHA, you will be well versed as to how you really evaluate your patients. How do you determine their coronary anatomy, their functional status, their coexisting medical conditions, and see what is the most appropriate treatment for that particular patient at that particular point in his or her life. So let us continue. Today, medicine has become much more complex. Our patients are extremely knowledgeable. They have very easy access to information, or I should say misinformation, from multiple sources in the social media, and hence it is important for us to involve our patients as a decision-making person along with their family, so that we fully educate them as to what their condition is, what is their status, what is their prognosis, and what we recommend based on guidelines directed medical management or interventional management. Again, cardiac surgery, just like coronary intervention, is a multidisciplinary approach, especially cardiac surgery. When we are talking about sending someone into cardiac surgery, it is just not a cardiologist's decision. The cardiologist will be involved, the cardiac surgeon will be involved, the anesthesiologist will be involved, and we also have other specialists like endocrinologists, renal specialists, hypertension specialists, pulmonologists. All of these people are going to be taking care of these patients somewhere during the course of the hospital, and hence a team approach is of paramount importance in making the right decision as to what is appropriate for that particular patient based on their clinical presentation and cardiovascular status. So you have to look at shared decision making. Again, it depends upon, is this an urgent, is this an emergency, is this like a salvage type of procedure. Then we need to look at following procedure. What are the things we need to be concerned about? Antiplatelet agents, aspirin, physical rehabilitation, psychological support, and many other factors. Anyway, so whenever we are talking about evaluating a patient for a cardiac surgery, especially coronary artery bypass surgery, be it like urgent, semi-urgent, or elective, we should look at their STS risk score and assess what is the risk of this person going for a cardiovascular procedure such as bypass surgery, depending upon their coronary anatomy, depending upon their coexisting medical conditions, their age, and their creatinine, and many other things. And we also need to keep into account certain things that are not covered in the STS risk score. If you don't know how to get to STS risk assessment, just type bypass surgery STS risk score assessment in Google, and that will take you to the STS Society of Thoracic Surgery website, where you can plug in all the numbers from your patient, and it will tell you what the risk is. Is it 2%, is it 5%, or is it 8% risk of this person going for any procedure or surgery? We also need to take into account certain other conditions such as cirrhosis, malnutrition, which is very common in elderly population. How functional is that person? If that person is barely getting around, then you really need to seriously question, what is the coronary artery bypass surgery going to do for this patient in the long run? A serious question we should be asking ourselves even before we can talk to the patient. There are various types of surgeries that we'll be coming across, just like in coronary interventions. It could be an elective procedure where we have stable ischemic heart disease, which is progressively getting worse. There's evidence of reversible myocardial ischemia. We think revascularization using stents or coronary artery bypass surgery would improve their symptoms, would improve their overall left ventricular function and their longevity, and that's a procedure which can be done electively. Then we want to make sure that we eliminate all other factors such as antiplatelet agents or blood thinners and minimize the risk, get their diabetes under control before we go for surgery. If it's an urgent procedure, a patient with like an unstable angina pectoris who comes into the hospital, whose condition gets worse, he gets chest pain, he's got arrhythmias, he's got heart failure, or she has got heart failure, then it may be time to do a coronary angiography, and if that is suitable, then we need to consider an urgent intervention, maybe during that hospitalization for those patients. Then we have the emergency surgery. These are patients who are unstable as they walk into the emergency room. They may have had a myocardial infarction, they may have heart failure, they may have like papillary muscle dysfunction or an aortic papillary muscle dysfunction, or they may have cardiogenic shock. In these circumstances, we have to see, would surgery help to stabilize this patient? Then finally, we have emergency surgeries like aortic dissection, or somebody who has an MI whose condition gets worse, they're going to heart failure, shock, and then we have to decide, would a salvage intervention like a failed PCI and the patient becomes unstable, would a salvage bypass surgery help to save this patient's life and hopefully minimize any further worsening of the condition or involvement of lungs, kidneys, and other vital organs? Anyway, this is ACC AHA guidelines. So of course they are going to be making recommendations, and they are based on class 1, class 2A, class 2B, class 3, and basically class 1, which has strong evidence of multiple randomized clinical trials showing benefit which far outweighs the risk. I want you to kind of imprint this image in your mind, because this is what is going to direct as what you recommend for your patients. Class 2A is moderate benefit. So the benefit a little bit overweighs the risk. Class 2B is weak. It is based upon non-randomized clinical trials, or it may be based upon expert opinion where the risk and benefits are equal. So that's something we have to decide. Generally speaking, from a learning perspective, or if you're taking a board exam, you need to be aware of class 1A indications for any procedure in cardiology. And you should also be aware of class 2A to some degree, but most importantly, you need to be aware of class 3 harmful procedures that can be more risky than any benefit that patient may get, and those are the things that we want to avoid, and you may get questions on that. That is something you have to understand what needs to be done in those patients. Class 2A is moderate. We already talked about this. Let's continue with this. And here, they not only look at the class, but also they look at what kind of studies are supporting these classifications. These are all based upon experts looking at hundreds of randomized trials or meta-analysis of some of these trials, and see if those data give us any guidance as to what is what could be useful to your patient. Then next thing is, of course, they are going to have coronary angiography before the cardiac surgery. We need to look at the complexity of the coronary arteries. Are we dealing with the left main? Do we have a proximal LAD lesion? Do we have a bifurcation lesion? Is there heavy calcification in the coronary arteries? Are there multiple stents? I heard of some patients having like 32 stents. Where is the place to put the bypass? And the state of the arteries, because in diabetics the arteries are very small, thready, and they may not be able to sustain a vein graft or a lima. So the length of the lesion and multiple tandem lesions, all these things need to be taken into consideration when we are evaluating the risk of surgery, and of course what benefit that patient is going to get from doing such a procedure. And here is a very complex chart. It looks like that, but it is extremely simple. If you have been I have followed thousands of cardiac surgery patients at the Texas Heart Institute in the 80s, 90s, and 2000s. So I'm very familiar with, how to evaluate a patient for a coronary artery bypass surgery. What are the things we need to do before surgery? What are the things we need to do in the immediate postoperative phase? And what are the things that we can use to determine what the outcome is going to be? In a stable ischemic heart disease patient, mainly the reason we would send them to surgery is because either they have multivessel disease, or they have left main disease, or they have a history of diabetes with low left ventricular ejection fraction. So these are all combination of factors that determines who goes for coronary intervention and who goes for coronary artery bypass surgery. I'm sure there are some centers who can take a diabetic patient and do triple vessel stenting and still come up with reasonable outcomes. But in the long term, which is better, coronary artery bypass surgery versus multiple stents? Because eventually those patients may end up needing a surgery, and if they need surgery, you hope they have some arteries left where the surgeon can put a bypass. And again, as I said, patients with diabetes have small arteries, and if you have multiple stents, what's going to be the challenge for the surgeon. Anyway, let's talk about stable ischemic heart disease. I don't know, we got an extra G here, apologize. Anyway, stable ischemic heart disease, refractory angina on medical treatment. So it's kind of oxymoron. We say the patient is stable, but it's refractory. That means the patient is having progressive symptoms. Anyway, if the person is having progressive symptoms on medical treatment, a revascularization may be a class 1 indication. If they are not having refractory angina on medical treatment, then we have to determine the coronary anatomy and the left ventricular function and the coexisting medical conditions to determine what is the optimal choice of treatment. If they have left main coronary artery disease, is the stenosis very complex? If the stenosis is suitable for coronary artery bypass surgery, then it is a class 1 indication for coronary artery bypass surgery. If it is not a suitable artery for bypass surgery, I'm talking about not the left main, I'm talking about the other branches beyond the left main, then a heart team has to get together and decide what is the optimal treatment. If the coronary anatomy is not suitable, then we have a choice of either doing a PCI or coronary artery bypass surgery. Anyway, so if this is not a left main coronary artery disease, then we are dealing with multivessel coronary artery disease, and does this patient need a surgery? If this person is not controlled on medical treatment, then we look for any evidence of ischemic cardiomyopathy with an ejection fraction less than 50%. If there is reduced ejection fraction, and if they have multivessel coronary artery disease, they are suitable for coronary artery bypass surgery. It is a class 1 indication for coronary artery bypass surgery, especially if they have an ejection fraction of less than 35%. If the ejection fraction is 35 to 50%, it is a class 2A indication, but still you would be okay if you recommend this patient for coronary artery bypass surgery. However, if the ejection fraction is greater than 50%, if the person has triple vessel disease, then it is a class 2B indication for coronary artery bypass surgery. These patients can go either way as long as their left ventricular function is normal. If they have triple vessel disease, either they can go for coronary artery bypass surgery if there is a compelling reason like diabetes or other problems, or they can go for PCI and then see how they perform. Patients with left ventricular dysfunction and multivessel coronary artery disease. In a sense, I already covered that in that flow chart. If the ejection fraction is less than 35%, multivessel disease, and especially if this patient has diabetes, it is a no-brainer. Coronary artery bypass surgery is the preferred method of treatment to improve their symptoms and survival. Whereas in a patient with the stable ischemic heart disease, multivessel CAD, the rejection fraction is 35 to 50%, and it includes left main coronary artery, and you can use the left internal mammary artery or radial artery to do bypass surgery. Then it is reasonable to consider coronary artery bypass surgery. Already talked about left main disease, so let's not try to repeat that. Let's move on to the next one, multivessel CAD. I already mentioned this in that flow chart, which was probably one of the best ones, and stenosis of the proximal left anterior descending artery. In patients with stable ischemic heart disease, normal left ventricular function, significant stenosis in the proximal LAD, the usefulness coronary revascularization to improve survival is uncertain. That is, there is no study to show that doing intervention, either bypass surgery or coronary intervention, is going to improve survival. But there are some newer studies which show that in a select group of patients, it may improve survival, but this is according to the guidelines. That's an important thing to keep in mind. We are doing the surgery to improve their left ventricular function. We are doing it to improve their quality of life. We are doing it to improve their symptomatology. As far as whether we can improve survival, that is not certainly established. But in patients going for coronary artery bypass surgery with lower ejection fraction, it is clearly established that their survival improves following coronary artery bypass surgery. Coronary artery bypass surgery for symptoms relief. When we are talking about using coronary artery bypass for symptoms relief, first of all, they have to be on maximum medical treatment. Next, their coronary arteries have to be suitable and amenable for coronary revascularization. Then a coronary artery bypass surgery may be considered, which is a class 1 indication, to improve their symptoms. On the other hand, if their coronary anatomy is not suitable for revascularization, if they have poor distal vessels, if they have multiple vessels, if they have a lot of scarring, which will not be improved by coronary artery bypass surgery, severely reduced ejection fraction like 10, 12, 15% with a lot of scarring, then it may be harmful to subject them to surgery because they may not come out of the surgery, and even if they do, they may be severely disabled for a prolonged period of time. And I have seen this in my practice. That's why I'm bringing this up. Anyway, poor, heavily calcified aorta is an independent risk factor for people going for coronary artery bypass surgery. But nonetheless, in older adults, as in all patients, treatment strategy for coronary artery disease should be based upon individual patients' preference, their functional classification, cognitive functionality, and life expectancy. Talking about diabetes and coronary artery bypass surgery, I already talked about why we need to do surgery in surgery for patients with diabetes, triple vessel disease, and perhaps reduced ejection fraction. And in these patients, it is important to make sure that lima is used to bypass the LAD, and preferably a radial artery or a rima to bypass one of the second major branches in the circulatory system. In patients with diabetes and multivessel CAD amenable to PCI and indication for revascularization, and they are poor candidate for surgery, then a PCI may be useful in reducing their ischemic or outcomes or symptoms. Coronary artery bypass surgery, this is very unusual. may be an alternative to some patients with multivessel disease who could be candidates for PCI, but they cannot tolerate the dual antiplatelet therapy. In those patients, they may be suitable for coronary artery bypass surgery, following which they may be on just aspirin. Chronic kidney disease, contrast, and complications before, during, and after surgery. As I said, I followed thousands of cardiac patients going for surgery. Chronic kidney disease poses a lot of challenges because these patients have more significant atherosclerosis. They have calcification of the aorta. Their arteries are really stiff. They are more prone for embolic events from the atherosclerotic plaque in the aorta, which can go to brain or to the kidneys and make their kidney function worse. The contrast also can worsen their kidney function even day before go for surgery. So in patients with chronic kidney disease undergoing contrast media injection for coronary angiography, we want to make sure we minimize the amount of contrast that we use. We hydrate these patients very well and protect their kidneys and closely monitor their kidney function. That's a class 1 indication. In patients with STEMI and CAD, coronary angiography and revascularization are recommended with adequate measures to reduce acute kidney injury. And of course, we look at the bottom here. In asymptomatic patients with stable coronary artery disease and CKD, routine angiography and revascularization should not be recommended unless there is a compelling indication that you're dealing with a critical stenosis in a main artery or a main branch, and we need to look at certain perioperative situations. In patients undergoing coronary artery bypass surgery, establishment of multidisciplinary evidence-based perioperative management involving cardiologists, CV anesthesiologist, pulmonologist, renal person if it's needed, and an endocrinologist. Further down, we'll look at a slide which shows that control of blood sugar is of paramount importance in preventing sternal wound infections. And of course, these are all anesthetic-related guidelines. The patient needs to be subjected to minimum of opioids, and intravenous agents may be preferred versus opioids, which may depress cardiovascular function. And of course, the use of TEA in routine coronary artery bypass surgery is not generally recommended unless we are dealing with a patient with significant other problems like left ventricular function or wall motion abnormalities or heavy calcification, things like that. Pulmonary artery catheters. There are some institutions which swear by that everybody who is, whether they go for single vessel bypass or double vessel or triple vessel disease, and if the ejection fraction is normal or abnormal, it doesn't matter. Everybody comes up with a little swan gans hanging from their head. And there are institutions, I worked in both institutions, that's why I know. There are institutions where they feel that pulmonary artery catheter does not add very much to the clinical findings which we can use at bedside, and also there is the added source of infection, especially in diabetics, which can lead to other problems like sternal wound infection and other things. So it is highly institution based, and that is something which you have to get used to depending upon where you work. Now, recommendations for bypass conduits in patients undergoing coronary artery bypass surgery. Of course, what we use to bypass a given artery is of more importance than just doing the surgery itself. For example, if at all possible, if we can use the lima to the left anterior descending branch and a radial artery or a right or rima to bypass the second largest branch, it is a class 1 indication. And in patients undergoing coronary artery bypass surgery, internal mammary artery is preferable to the left to bypass the LAD, which I mentioned. And internal mammary artery, bilateral internal mammary artery grafting can be used. That depends upon the surgeon's experience in extracting these arteries and making the connections. Of course, the bypass conduits. We talked about these valve and coronary artery bypass surgery. If patient undergoing a valve surgery, say for example aortic stenosis, has one or two vessel coronary artery disease, or other kinds of surgery like mitral valve replacement, then coronary artery bypass surgery is generally recommended during the valve replacement to reduce perioperative ischemic events. Because the worst thing that you can expect a cardiac surgery patient is to have a perioperative myocardial infarction, which greatly increases the risk of complications. So we want to avoid any possible ischemic event in the perioperative phase. In patients undergoing valve surgery like aortic surgery or other conditions have intermediate coronary artery disease, CABG may be reasonable, and this is a 2B indication. So if they have reasonable coronary artery disease, then that's an indication. And here is ultrasound. Using ultrasound in patients undergoing coronary artery bypass surgery, routine use of epi-aortic ultrasound scanning to look for evidence of calcification in the aorta or a lot of sclerosis, which can lead to atherosclerotic embolic events, is something that can be considered, but it is a 2A indication. Recommendations for use of cardiopulmonary bypass in patients undergoing CABG. Of course, in the 80s and 90s, everybody went on a heart-lung pump when they were getting bypass surgery. Nowadays, we have surgeries that are done off pump with just stabilizing the heart, and so it is reasonable in patients with significant calcification of aorta to use techniques to avoid aortic manipulation. Off-pump techniques or beating heart, that's a class 2 indication to minimize embolic events. In patients with significant pulmonary disease, off-pump surgery may be reasonable to reduce perioperative complications. Sternal wound infection, it is just part of the coronary artery bypass surgery scenario. I have seen multiple patients who come back with sternal wound infections, and you have to understand sternal wound infections are going to happen, and we don't know, but patients with diabetes are more prone for sternal wound infections, and patients with compromised immune system are more prone for sternal wound infections. That's why here it says it is class 1 indication to maintain their blood sugar levels below 180 milligram per deciliter. This could be your question in a board exam, by using insulin infusion in the perioperative phase. Similarly, we have in patients undergoing CABG, use of continuous insulin to keep the blood sugar under control is of paramount importance, and it's a class 1 indication. And use of keeping the blood sugar below 140, there is no documentation that it is better than keeping the blood sugar below 180. So that's an important information on this slide with reference to reducing sternal wound infection and how do we maintain blood sugar levels at a reasonable level without causing hypoglycemia and problems related to hypoglycemia. All right, so the sternal wound infections, here are some of the other things that are related to sternal wound infections. And sternal wound infections may show up as just like a small redness, erythema, or maybe a small pustule. And remember, as a cardiologist, you are the only person who is really looking at the patient's chest and listening to the heart. When you do that, look for any evidence of any redness, erythema, or a small drainage. There could be a pool of pus underneath that little boil that you see, and that's when we need to bring it to the attention to the surgical nurse or the surgeon so that they can tackle this in the early stages of any possible sternal wound infection. Of course, we have to minimize all these risk factors like diabetes, smoking, post-CABG antiplatelet agents. here, class 1 indications. I'll just read the first one here. In patients undergoing coronary artery bypass surgery who are already taking daily aspirin perioperatively, it is recommended that they continue taking aspirin until the time of surgery to reduce ischemic event. This could be one of your board exam questions. Similarly, we have lesser evidence based on non-randomized trials. Patients referred for coronary artery bypass surgery, Plavix and ticagrelor should be discontinued for at least 24 hours to reduce major bleeding complications. We come across this quite often. Patient goes for interventions, gets 600 milligrams of Plavix. Now we feel that the procedure is not successful, then we send them to surgery. Invariably, they come up with bleeding problems which the surgeons hate. So here is no benefit in patients undergoing elective coronary artery bypass surgery who are not already taking aspirin. Starting aspirin 100 to 300 milligrams in the immediate perioperative period, that is 24 hours before surgery, is not recommended. So if they have not been on aspirin, do not start them on aspirin 24 hours before the surgery, and that is like a contraindication. All right, so let us recommendation for beta blockers. Again, in patients who are undergoing coronary artery bypass surgery who do not have contraindications for beta blockers, the administration of beta blockers before surgery can be beneficial to reduce postoperative atrial fibrillation. This I can say from my own personal experience, because 1/3 of the patients going for coronary artery bypass surgery invariably have arrhythmias, and most often it is atrial fibrillation with rapid ventricular response. So routinely, if their blood pressure and the rest of the cardiac conditions were stable, I started them on low dose of beta blockers like metoprolol, 25 milligrams once or twice a day. And believe it or not, many times these patients go into atrial fibrillation, but they are not having a heart rate of 180 to 200. They may have heart rate of like 110, 120, 130, which is far better than having a atrial fibrillation with rapid ventricular response. So I can say from personal experience, using beta blockers in the perioperative phase is a good idea. In patients undergoing CABG, perioperative amiodarone is reasonable to reduce postoperative atrial fibrillation, but the amount of amiodarone that you're going to need, like 4.5 grams, to load them to a level where it can reduce atrial fibrillation with rapid ventricular response, I don't know. I don't think that would be my first choice. In patients undergoing coronary artery bypass surgery who do not have contraindications for beta blockers, perioperative use of beta blockers may be effective in reducing in-hospital 30-day mortality rates. And this is, of course, based on non-randomized trials. So I think the use of beta blockers is much more so in trying to prevent rapid ventricular response if these patients develop atrial fibrillation, which they often do following coronary artery bypass surgery, or if they have, for example, valve surgery, mitral valve surgery, the chances of them going into atrial fibrillation with rapid ventricular response is like 50 to 70%. If they have pulmonary surgery, it is almost 70% chance of these patients going into atrial fibrillation with rapid ventricular response. Okay, CABG and aspirin. In patients undergoing CABG, aspirin should be initiated within 6 hours following surgery. Now remember, you do not start them 24 hours before surgery, but after surgery, you want to keep them on long-term aspirin, and it can be reasonably started the same day or the following day. In select patients undergoing coronary artery bypass surgery, dual antiplatelet agent with aspirin and ticagrelor or clopidogrel for 1 year may be reasonable to improve graft patency. This is like a class 2B indication based on some randomized trials. Okay, we are coming to the end, so let's see. Recommendations for beta blockers in patients after revascularization. In stable ischemic heart disease patients with normal left ventricular function, routine chronic use of beta blockers is not beneficial. So if their ejection fraction is normal and if their symptoms are stable, then there's no reason to use beta blockers in these patients for improving their prognosis unless they have other reasons such as hypertension or they have atrial fibrillation with rapid ventricular response. Atrial fibrillation, we talked about this. Let's move on. Cardiac rehabilitation. Cardiac rehabilitation is sort of a hit or a miss. There are certain centers where they do procedures, they do surgeries, patients go home and they are on their own. They start walking and improve your walking distance on a daily basis. But there are institutions which have highly structured 6 to 8 weeks of cardiac rehabilitation. If such a program is available at your institution, you should thoroughly use it because this will help you to develop strength, it will help you to develop stamina, it will help you to function better, and it gives you a lot of confidence that you can return back to your normal life much earlier than if you were just sitting at home and wondering about what's going to happen after the coronary artery bypass surgery. Psychological interventions. Coronary artery disease is very complex. When someone gets a heart attack, they stop smoking in the intensive care unit and for good. It is so shocking. And same thing with coronary artery bypass surgery. It shakes the very core of your life when you go through coronary artery bypass surgery. So a lot of patients will need a lot of psychological support. And this is something that is not usually addressed by cardiac surgeons or even cardiologists. Maybe the primary doctors should look for any signs of depression, which is very common following coronary artery bypass surgery. In fact, in women, depression is seen in as much as 50% of the people who have coronary artery bypass surgery, and we should look for these symptoms, refer them to a psychologist or a psychiatrist so they get proper counseling so that they can have a normal recovery following coronary artery bypass surgery so they can return to their routines. So ladies and gentlemen, coronary artery disease is a complex disease. It involves, there are multiple risk factors which we are all familiar with, like diabetes, smoking, hypertension, sedentary activity, and hyperlipidemia. And there are psychological factors which are drawing more attention recently because of the complexity of the coronary artery disease and the procedures that we do, which are very complex and also based on the left ventricular function. So ladies and gentlemen, recommendation for assessment of outcomes in patients after revascularization. How do we assess their outcomes? Class 1 indication is with the goal of improving patient outcomes, it is recommended that the surgery and PCI programs participate in state, regional, national clinical data registries and receive periodic reports on their risk-adjusted outcomes. And this is routinely seen now. Even hospitals take pride in publishing their surgical outcome results in order to attract patients. So that has become an integral part now. It is almost a requirement to report every case that is going for surgery and what the complications were and what the outcomes were after 1 year or 2 year or whatever the time frame may be. So similarly, small volume cardiac surgery PCI programs may consider affiliating with high volume centers to improve their outcomes. Obviously, if you're doing procedure once in a month or once a week, it may not be as efficient as someone who is doing 3 to 4 procedures per day. And that's where I worked at the Texas Heart Institute or the St. Luke's Hospital, where 40, 50 patients were going through coronary artery bypass surgery. And those were the days when they did the single vessel bypass surgery, double vessel bypass surgery, and those patients did reasonably well. And those bypasses lasted for a very long time, especially if you are using lima. So ladies and gentlemen, this is a long-winded coverage of ACC AHA 2021 guidelines for coronary revascularization with particular reference to coronary artery bypass surgery. How do we select the patients? How do we assess their risk? How do we assess their outcomes? And what are the things that we should be avoiding in these patients? Thank you so much for watching this presentation, and please do watch the other presentation which I have on coronary interventions guidelines
from the ACC AHA 2021 guidelines, which is of more importance, especially as a cardiologist or as a cardiology fellow. I'll see you in the next presentation. Thank you so much.